and David, Charlie, Kojo. Always an amazing course every year. I think it's one of the best in the country. And disappointed I couldn't make it there live this year, but appreciate the accommodations to present virtually. So I'm going to talk about essentials of adult deformity. Big topic. I'm going to kind of cruise through it, but it's a topic that's certainly of a lot of interest to me. These are my industry disclosures. Adult deformity is clearly an important topic, and not just because I'm interested in it, but it's important for a variety of reasons. For one, it's extraordinarily common, and so whether you're kind of affiliate yourself as a deformity surgeon or not, if you're treating the spine, you really need to understand a lot of the deformity concepts and management strategies. Deformity has an enormous clinical impact, and that's been demonstrated, through a variety of quality of life studies. This was a nice one Shea Best and ISSG put together, comparing adult deformity to other disabling chronic conditions, and demonstrated that deformity has a similar impact of conditions such as cancer and patients with limited use of arms and legs. So it's really a majorly disabling condition, and it's of interest to us as surgeons because surgery seems to help. If you track patients treated operatively versus non-operatively, the surgically treated patients on average get better, and patients that are managed non-operatively tend to follow the track they're on. But that comes at a tremendous cost, and study after study, we see these ultra high complication rates from the same study demonstrating that improvement of operative intervention. We see greater than 70% of the patients with at least one complication, and that's consistent across studies. So, how do we define deformity? Essentially, adult deformity is abnormal alignment in an adult over 18 from a variety of different etiologies, and there's been a long list of alignment parameters that have been studied to try to understand what's meaningful. And we're going to boil down, the coronal and sagittal plane to two lines. This would be where global coronal balance seems to be important. What happens in between the residual Cobb angles seems to be less important. But it's really the sagittal plane and getting that right that seems to have the greatest impact on quality of life. And the big question has been, what are those sagittal plane targets? And that's really kind of an evolving topic, and it's really built on the foundation that was set with these three parameters. This is, I think, routinely taught in all the programs now, as it should be. But it's become clear that this may not really describe the whole story, and that it may be a little more nuanced than this. You can, if you look at studies where patients are matched very well based on these three parameters here, you still have high rates of mechanical failures. And quality of life is not where it should be. So, there's been other kind of variations of this that have been proposed. This is, from the ISSG building on their work, suggesting that maybe older patients shouldn't be hitting those same targets. Maybe we should be undercorrecting them relative to normal. Adults as they age normally degenerate, normally lose lordosis. So maybe we shouldn't be trying to make them look like they're 20 years old. And they've demonstrated that they may have some mechanical advantage by taking that approach with this paper here on the right. There have been other concepts that have been introduced, and this is kind of a different approach that was introduced by the ESSG in Europe with the GAP score, which really tried to redefine what is normal, and still building on the Schwab classification, but looking at it a little bit differently, where proposing that the ideal lumbar lordosis is not as simple as PI minus LL, but is governed by a different type of equation that's dependent on PI. And that ideal values such as PT is not less than 20 is not the target for everybody, that it goes up with higher PI, given that higher arc of retroversion, anteversion of the pelvis. And that distribution of lordosis matters. So, if your target's 50, having, 40 of that in the upper lumbar spine is probably not ideal, and trying to restore more physiologic lordosis, and what's physiologic is up for debate, but there's been more and more normative studies to look at this. And in terms of the distribution, this is a nice study from 2018 that looked at the distribution for low PI, kind of middle PI, and high PI, and really showed that the L4 to S1 lordosis was pretty constant across all the pelvic incidents. That the differences was really in the upper lumbar lordosis for those higher PI patients, and so really, and this has been redemonstrated in other normative studies as well. So if you're hitting an L4 to S1 lordosis somewhere between 35 and 40, independent of PI, that's probably a target that you want to keep in mind. I think that's a good number to keep in mind, and certainly something I use to gauge what I'm trying to accomplish. Rousseli classification, also a lot of discussion about, really introduced spinal shape, not just kind of PI based derivations, but different types of shapes based on your PI and where your lordosis should be. And it's it's very similar to some of the concepts in GAP score. And there's been quite a lot of work around this, and it's been demonstrated that failure to restore the ideal Rousseli type was independently associated with mechanical complications, and that this restoring ideal shape and kind of putting the lordosis in the right locations, the right magnitude of lordosis, right location matters. So the really when evaluating these patients, really given the high complication rate, given really the variety of people you're seeing, and just kind of complexity of spine in general, the first question is the deformity primary to the complaint? With everybody getting drilled in about SVA, everybody that has a positive SVA does not need a T10 to the pelvis, and this is a good example of somebody that's leaning forward, has a positive SVA of 10 centimeters or so, but you can tell they're not engaging any of their compensatory mechanisms. They have a low pelvic tilt, kind of a normal thoracic kyphosis, and this is a patient that's claudicating and flexing forward and leaning forward, not because they have a deformity. So this patient just needs a laminectomy and doesn't need a big reconstruction. These are nuances you need to be paying attention to. So everybody with a positive SVA is not somebody that needs a big surgery. But for patients that do, so if you find somebody that you really are confident their deformity is playing a major role in their quality of life, and they've failed non-operative strategies, given the magnitude of a lot of these operations, and there's different ways of doing it with less invasive approaches, which does reduce some of the the surgical footprint. But regardless of how you slice and dice, it's a big surgery, and so really determining who's a good surgical candidate and who's not, and paying close attention to these modifiable factors. There's some things you can't change, or age, or genetics, but then this list here are things you can and should pay close attention to, and you can have a whole lecture on each one of these, and they often do at SSF talking about these topics because they're incredibly important. So these are things you need to learn how to think about, manage, and it's important in degenerative spine. It becomes even more important in deformity. So you've decided somebody needs a surgery, and they go into the treatment planning. And so the first steps in your treatment planning is really defining the location, the magnitude, and then of critical importance, the flexibility. And there's a variety of ways of measuring flexibility. You can use push prone, lateral bending. I tend to rely heavily on supine x-rays, and most of the time I'm just using CT scouts, which give me the information that I need. And I'm getting preoperative CTs on most of my deformities to begin with, and I use that information when you eliminate gravity, see how the spine responds. And then you make your plan, and you how high up do you need to go, how low do you need to go, and there's various considerations in that. That's a big topic by itself. And then what osteotomies you need to do. And this is the Schwab classification of osteotomies. There's really two clusters here. There's the 1 and 2, type 1 and 2 for mobile segments, and then the 3+ for really reserved for fixed deformities that require a 3-column osteotomy of increasing invasiveness from 3 to 6. Do you need to decompress? Looking at your nerves, what type of instrumentation you're going to do, what type of pelvic instrumentation, how many rods, and then how you're going to do your biology for your orthodesis and all your prep. And these are all really important components to doing a good surgery and being thoughtful about it. So I thought I would, just take through a case. So this is, a patient actually just saw back and follow up this past week. So it was kind of fresh in mind. Interesting case. And I think, it kind of illustrates some of the planning. So that this is where I have the patient presented to me with this, pretty severe kyphoscoliotic curve. See some of the measurements there. Hard to see the femoral heads. There's actually seated X-rays. Patient stands and walks, but was not able to stand long enough to tolerate standing X-rays. Ended up getting these seated. But he was actually plugged into our system. This is interesting. So he was, you see that pain pump there, and he was in our system. One of our neurosurgeons that does neuromodulation, he was established with and was managing his pump. And so we have actually scoli X-rays going back to 2017. So this is just 6 years ago, what his spine looked like. And he had a prior 3 to 5 fusion and alignment pretty good. A little bit adjacent segment above it, but overall pretty good. Next set of X-rays we have was 3 years later. We can really start to see the spine starting to collapse, pretty rapidly over the course of 3 years, and then 3 years later, this is where he's at. So I would classify this as a fairly rapidly progressive scoli, which in my mind often means flexible. It's happening quickly, and so hasn't had a time to become rigid. Most adult deformities are rigid, different than adolescent deformities, but ones that progress this rapidly are often more flexible. And so, I got my CTs to try to kind of better define the deformity, better define the location, the magnitude, all of that. And you can see in the sagittal plane quite a bit of relaxation. That thoracic and thoracolumbar kyphosis reduces pretty well. And coronally, it kind of has an appearance that it reduces as well. If you measure the angles, actually not that impressive. The thoracic spine straightens out a fair amount. But you look at that pelvic obliquity, and if you go back to his 2017 X-rays, he doesn't have pelvic obliquity. That's really a compensatory reaction trying to torque his body over to stand up straight. And so if you kind of do a T-bar of his supine CT scout here, you see he's really coronally actually very far off, and so not very flexible when you look at him supine. If you look at the CT, you can see what's going on here. It's really the thoracic kind of flexible scoli really just opened right up. You see the vacuum disc on the concavity there that opens up when he lays supine, and you see that really significant focal deformity at L1-2, which has become rigid, looks like it's probably autofused, and is not really changing much with gravity. And so about a 40-degree focal scoliotic deformity there is really driving this whole problem. And then if you look in the sagittal plane, that's the focus of the sagittal plane deformity as well. And he has some poor neuromuscular reserve, obviously, because he's really falling forward in the upper thoracic spine, despite only this 20-degree kyphosis. But really, the thoracic kyphosis straightens out. It's just this rigid kyphotic deformity here. So, if you look at the numbers, they're really not too far off of what we're trying to accomplish. If we're trying to get to a 35-degree 4-to-1 target, not too much more work is needed. And the same for lumbolordosis. So, it seemed kind of a daunting surgery up front. Really, most of the work just really needs to be done at L1-2. In terms of UIV, LIV, this is definitely somebody I know I need to go long on. They don't have a lot of musculature to support the spine. So this is not somebody I'm going to try to stop in the lower thoracic spine, even though the deformity is really upper lumbar. That's a very high risk for failure, really high risk of PJK. So this is when I wanted to go to the upper thoracic spine initially, and then spend my time at L1-2 to try to correct that deformity with a disc-based osteotomy at L1-2. And so, intraoperatively, this is what I do for intraoperative measurements. It's basically a stitched fluoro, which does a nice job. It's a little bit more efficient, at least at our institution, than trying to bring in plates and stools and trying to get 36 inches, which are often not clear. You can't see the pelvis, et cetera, at least at our institution. So I tend to like this, since this is after positioning before doing any work, and you can see that rigidity there, and still how far off to the side. And so we just stuck with our plan, placed our implants, and and focused on that L1-2 area. especially on that concavity, just vasectomy there into the disc space, and just worked that disc space to do that disc space osteotomy, and able to get a nice correction, and really without a ton of work, really just focusing on that L1-2 level. There's the post-operative CT where you can see it really kind of restore that focal kyphosis and the focal scoliosis there as well. And we're able to achieve our kind of lumbar alignment parameters. And we just saw him this past week back in his 3-month post-op, and he's a guy with he's doing very well, much more mobile than he was. He still has a long recovery ahead. He was on he's got the intrathecal pump with lots of opiates, and he was supplementing that with tons of oral medication. So we're actually weaning him off. He's coming down. He's still struggling during that process, as you'd expect. But overall, happy with how he's standing, and in a much better place than he was. And there's just his pre to post. So, just to allow some time for some discussion, to summarize, adult deformity is very common, and kind of depends on how you want to, define deformity. But, in our aging population, we see this more and more. And, we know that surgery can be very helpful, but we need to be thoughtful about what surgery we're doing, trying to minimize, what we're doing, and try to, I'm showing an enormous case. We're going from T2 to pelvis. That's not my go-to unless it's absolutely necessary. Really trying to do the smallest operation that's going to get them to a better place and have a durable outcome. And then without a crystal ball, it gets a little difficult to predict that. But using literature and using your clinical acumen, you can really help patients in a meaningful way by being thoughtful about it. Address your modifiable risk factors. That will certainly help your outcomes. Most of these patients, if they're not myelopathic, if they're not losing neurologic function, most of them can wait a little bit to really get these modifiable risk factors addressed. And realignment targets are clearly still evolving. Some people talk about it like we have all the answers. I see this as something we're still learning, and something we need to rely on all of you to help us learn more about. And I think the spine is a very complicated structure in terms of alignment. It's a very unnatural thing we're doing with deformity. So still a lot to learn, and it's exciting to be part of it. It's part of what drew me to deformity to begin with. So thank you for your attention, and happy to answer any questions and discuss any of these topics further.
Jay, thank you. Applause for you. I really loved your dynamic x-rays, and I would like to add to that maybe in the future we can actually do a physical exam where we have a recumbent test or something like that to actually test the flexibility, which incorporates hip motion and knee flexion contractures. Yes, that's the orthopedic surgeon in me speaking. Answer me the question that I frequently get posed in other settings of non-spine surgeons, that is, are we over-operating on patients, and how much are we creating ourselves in terms of more and more spinal deformity? Is this a reflection of the ill health of society, an aging society, or are we creating more and looking for more deformities by adhering to tight mathematical formulas?
Yeah, no, I think it's an important question, a great point. Yeah, I think it's a combination of both, right? I mean, a large part of my practice as an adult deformity guy is revision surgery, and so it's I think some of those surgeries were for mobile spondies that probably needed a fusion, and some of them aren't. You look back at preoperative films, and you start this cascade, this degenerative cascade that ends up so look at that guy. He was a 3 to 5 fusion. Look what he ended up with. Whether that was what provoked all this, if it was necessary. But if you look at his preoperative films, it wasn't anything too impressive that seemed to justify 3 to 5 surgery. Now he's got a T2 to pelvis. So I think it's a fair point. Our methods of correcting it are very crude. We're putting a bunch of metal in, putting the spine in this very non-physiologic state, and it's lucrative, and so people are incentivized to do more of it. So I think we have to have a very tight moral compass to try to do right by our patients and be thoughtful about it. But I mean, it's one of the most common reasons people are failing boards for their cases is being too aggressive, putting too much metal in, kind of reflexively doing T10 to pelvises on people that don't need it. So I think it's complicated, but I think your point is an important one.
So many things to talk about, and again, my thoughts are stirring with things I'd want to ask you, but let me just reduce it to one question. Carlos Bagley and the team at UT Southwestern, I'm obviously very fond of my colleagues there, put out a great paper that reevaluated something like 300 odd adult spinal deformity patients, and about 80% of them, these patients said they were good or happy, and they'd do it over again. 20% were not good. And when you talked about patient optimization, those that did not do well had a statistically much higher preponderance of anxiety and depression. Are we doing enough as surgeons to kind of screen for these problems?
Yeah, no, I think I think that's an important point. There's programs like Upper Virginia Mason, but that's a routine part of their screening protocol for complex spine. They have a psychiatrist at the table, and they actually weigh in on the mental health and mental fitness for surgery. It's something we don't have as standardized at our hospital, at our program, but something I certainly think about and screen for individually. Who's going to do well and who's not? It's so complicated and it's so hard to predict. And, we all have our kind of gestalt about how somebody's going to do. And some anxious patient that's depressed that ends up really surprised, who has a real problem that you decide to fix anyway, who does phenomenally well. And it's, it could be a bit of a chicken or the egg. Is the deformity driving the mental health, or is the mental health really going to inhibit their recovery? And we don't know. We're not good at predicting. I think, as we get more sophisticated with our data and we can do better predictive analytics, maybe we can get a better guess about how somebody's going to do. But right now, I think we're very poor at predicting who's going to do well a priori.
All right. Well, thank you again. Great.
Okay. Thanks for having me.